Very good evening.
Very good evening. Krishna, just one question.
Yeah, please carry on, Rajdeep.
You just spoke about all those benefits with this molecule.
Yeah.
Like OSA, new onset, anemias, and
Yeah.
cardiomyopathy,
Yes.
and neuropathy, and decrease in uric acid level, which is also there with the DAPA definitely. I'm just asking the basic question.
Yeah.
All these beneficial effects are there particularly with the empagliflozin molecule, not with the dapagliflozin. This is the one question.
This is your first question, right?
Yeah.
It's a wonderful question, Rajdeep, actually. Dapagliflozin has got all the benefits what I have told with dapagliflozin. It is
I got it.
a head-to-head fight because the table I have shown is these are all the primitive studies. The first studies done with either the DAPA, that is DAPA declared TIMI 58, or the canvas, or the what is CV, or the first COVTs. Whereas we have compared with the second COVT of empagliflozin. First COVT of empagliflozin is only empiric. Second is empiric outcome. There comes the difference. I have told there itself. Later on, they also have done dedicated studies like DAPA CKD, the DAPA HF, and the credence with canvas and the canagliflozin. Later on, not the canagliflozin, not the etigliflozin. The out of three molecules which are available in India, empagliflozin is comparable with dapagliflozin and vice versa. Dapagliflozin has got all the benefits which I have mentioned.
Okay.
Is it clear, Rajdeep?
It's clear.
So, but only thing is, you want to combine anything. It's always better to combine the DPP4 inhibitor. The linagliptin stands first. That has got lot of advantages, either with the dapalina or empalina.
Okay.
See, the greatest advantage if we add the linagliptin is that the side effect of this particular, all the time the companies, Rajdeep, they highlight the positive aspects. They never highlight the negative points of this particular. They see the negative aspects are so many things are there, starting from the euglycemic decay, the dehydration, and the genitourinary tract infections, and the vaginal candidiasis in the form of either vulvitis or vaginitis or vulvovaginitis, or fasciitis or belonitis or bellopasciitis in the males. They don't mention all these things. So many side effects are there. Where to be used, they mention. Where not to be used, I mentioned, Rajdeep. This is very important to the clinicians. It has got some barriers where it is to be used. You cannot use it if the patient is dehydrated. You cannot use it in type 1 because of the euglycemic decay. Either in see, I want to tell you honestly, the European Union for the last 4 years has been using this molecule, empagliflozin and the canagliflozin, the dapagliflozin and the sotagliflozin in type 1 diabetes also. This is the official recorded evidence-based medicine from the European Union and the European Medical Agency. The inference is that though there is little the increased risk of DKA, either it is DKA or euglycemic decay, but the insulin dose is very much reduced in the patients suffering from type 1 diabetes with addition of these drugs. But as of now, US FDA has never recommended and our Indian FDA has never recommended. That is the reason I have told you in the beginning itself. This is a drug of choice for type 2 diabetes mellitus only, not in any other cases. The only case where you can use is the pre-diabetes, Rajdeep. Pre-diabetes you can use either the metformin or the SGLT2 inhibitor or the GLP-1 receptor agonist. These are the three drugs which are recommended in pre-diabetes because pre-diabetes is equivalent to diabetes with regards to the coronary events. So you have to take care of this particular aspect, the atherosclerotic cardiovascular disease, in a much better way as far as the pre-diabetes is concerned. So Along with metformin, the lifestyle modifications, they come first. The diet, exercise, reduction in the weight and cessation of smoking and cessation of alcohol, they are mandatory if at all you want to survive. And on top of it, you have to use metformin, which is very much underused. Only less than 3% are all over the globe are using metformin in pre-diabetes. See, other 97% of the patients are left to cats and dogs, Rasdeep. So that is the very pathetic point actually. Along with that, to save the patients, the cardiovascular events, you have to add the SGLT2 inhibitor or GLP-1 receptor agonist, which is a costly affair. I too totally agree, because we don't have a comprehensive insurance system in India, unlike the US or unlike the UK, where NIS is there in the US, whereas NHS is there in UK. So we don't have such type of comprehensive system. They give all the medicines free of cost, but even there also they bargain. The insurance companies, they do bargain. If the molecule is costly, they say no to that. Bluntly they say no. Like GLP-1 receptor agonists, they have to fight and get the approval from the insurance people actually. So we don't have any such insurance system. So only few, less than 1% of the patient population, they have got this reimburse system or the insurance systems which they can claim later on. Otherwise, it is very difficult in our scenario to initiate a GLP-1 receptor. Like, okay, you take even liraglutide, forget about exenatide, which doesn't have any cardiovascular benefits, forget about albiglutide. These two molecules are the useless molecules. Liraglutide is good, dulaglutide is good, and semaglutide is good, and on top of all, tirzepatide is the best molecule, which has got both the dual mechanism of action as GIP and the GLP-1 receptor agonist, Rajdeep. Is that okay, Rajdeep?
Yeah, thank you. One more thing, like you in the clinical practice, you said a new onset OSA.
Yeah.
So what I'm asking you, a very practical question, for a lot of patients come with many years of OSA.
Yeah.
Is this going to be beneficial?
To some extent, it is beneficial. See, you have to believe in something is better than nothing, and nothing is better than nonsense. In that case, you see, as a protocol, all these molecules, the empagliflozin and the dapagliflozin, have to be started very early in the course of type 2 diabetes mellitus. If at all you want to have the benefits, the cardio, renal, hepatic and the metabolic benefits, you have to start it early in the course. If you start late, you only have the metabolic benefits. It can reduce the fasting plasma glucose and the 2-hour post glucose and the A1C. The glycemic triad is addressed, but it cannot confer the benefits on the heart, benefits on the liver, benefits on the kidney. You can never expect. Like this, OSA also, to some extent, the chronic OSA, already it is there, because I told you OSA is directly the equivalent to, that is the heart attack. That's it. So you need to take care in a much better way. But weight reduction is the only the beneficial way where you can have this. And 40 years ago they used to do this for OSA and all. U3P, that is vulvopalato-pharyngoplasty, they used to do that. And now also this is the only surgical method available, Rasdeep. When we were doing medicine, I definitely remember that the Harrison's Principles of Internal Medicine, 13th edition was there. And by the time we came into Housey, 14th edition has come out. Both the editions mentioned the U3P, there was no SGLT2 inhibitors, nothing was there at our time. Only few drugs were there at our time only. Like sulfonylureas, the metformin, and the acarbose also was not there when we were doing our medicine, Rasdeep. Acarbose also was late in 95 or 96, not during our time. So there was not even an alpha glucosidase inhibitor. Only we used to manage with metformin and the sulfonylureas. Per se, the glibenclamide and the glipizide.
Okay, great.
Is it true or not, Rajdeep?
That's true. That's true. And
Yeah.
one more thing,
Yeah.
Krishna, this EMPA we start with 25 and we can continue for the rest of life with 25
Right,
also.
rest of the life, because all the studies done with EMPA are all the time. Either the EMPA reg or the EMPA reg outcome, or the EMPA kidney, or the emperor preserved or the emperor reduced, whatever it may be, are done with only 25 milligram and DAPA with 10 milligram. So never go for 5 milligram DAPA, never go for 10 milligram EMPA. All the time 25 milligram EMPA, all the time 10 milligram DAPA to have the benefits lifetime. It's only this drug. To highlight and they enlighten the audience, the participants. For example, I'll tell you only one example, like the fundamental, the medical management of the four pillars of the treatment of heart failure, approved by all the international societies of heart failure, including the Heart Failure Society of North America also. Every European Society of Cardiology, American College of Cardiology, American Heart Association, and the Heart Failure of North America, they have unanimously said there are only four pillars in the medical management. I am not talking about the devices and implants. Four pillars are: the first pillar being, if the patient is not able to go for this sacubitril valsartan RNA, either ACE inhibitor or ARB, or the patient is able to go for that, because now it is off patent. The research molecule of Novartis, the Vimada, the sacubitril and valsartan, and that is the first. And second is beta blockers, and third is the mineralocorticoid receptor antagonists. Again, the non-steroidal and the steroidal. Non-steroidal is finerenone, and steroidal is eplerenone and the spironolactone, which are widely used. Spironolactone is widely used, but now they prefer non-steroidal MRAs, that is finerenone. And last is SGLT2 inhibitors, only the EMPA and the DAPA, never CANA, please. So out of all the four, all the three, barring the SGLT2 inhibitors, they need the monitoring and the dose titration throughout the life. Only one drug that doesn't require any sort of monitoring, any sort of dose titration, is the empagliflozin 25 milligram and dapagliflozin 10 milligram. You can just start with the 25 EMPA, 10 DAPA, stay coolly, like, okay, you don't need to do anything.
And same with Lina, 5 milligram.
Yeah, absolutely. See, these are all the molecules, they rose without thorns, Rajdeep, actually. Wonderful. The linagliptin is the only DPP4 inhibitor or the gliptin that has got two dedicated cardiovascular outcome trials. The one is the Carbolina and the second is the Carolina, which no other, the sitagliptin or the vildagliptin, nothing. They don't have anything. Saxagliptin they have, but okay, they are proven to be, like saxagliptin is proven to be negative to this particular this heart failures. It induces heart failure, so saxagliptin ruled out, and vildagliptin is neutral, and the sitagliptin is neutral, whereas linagliptin is beneficial to heart actually. That's what the Carbolina has shown. That's what the Carolina with comparison with the glimepiride has shown actually. Finally.
Great. One very small question, last
Yeah,
one.
please.
Yeah, like you said, EMPA with the fat content, grade 1, grade 2, grade 3. So it will take care of grade 3 fatty liver also, and it will have some impact on the liver enzymes.
Yeah, absolutely. In the form of transaminitis, you find the ALT and AST raised with the alkaline phosphatase raised. That is that is defined as the transaminitis stage. That is the first finding we find in the biochemical findings. On the ultrasound, you find that okay, the best thing is after doing this and after doing this LFT, you find the transaminitis and all. It's better nowadays. All the gastroenterologists, medical gastroenterologists have got there in OPD the instrument called the elastogram, which can detect this. The staging of the particular, whether it is in the stage of NAFLD or NASH or the cirrhosis, whatever it may be, and even the advanced imaging systems like the CT, the abdomen and the the plain and the with the contrast and the MRI of abdomen. These are all the parameters, and you can manage the grade 3 also with all these the molecules. More than 10 to 12 molecules I have mentioned. Not only this empagliflozin, dapagliflozin, every molecule is important, and on top of it, weight reduction is the only one that is going to reduce the hepatic damage actually.
Thank you, Krishna.
Thank you so much, Rajdeep, and always that gives me a lot of pleasure if Rajdeep is in my session. Wonderful enlightenment to the participants.
Thank you. It was a really
See, this is the latest one, Rajdeep. This is the latest studies I have mentioned. It is A to Z of empagliflozin today I have covered. Until the last trial, I have starting from and last A to Z is covered in this particular this thing.
Here is the detailed literature of the EMPA.
Yeah. See, my property is your property.
Whatever you have taught us over here, it is not there. That's the problem.
See, if I have to prepare 150 slides, Rajdeep. It becomes Ramayana or Bhagavad Gita or Mahabharata.
Yeah, that's what I don't want to go through the Mahabharata. I just want to go whatever you have taught us.
Thank you, Rajdeep. So kind of you.
Thank you, Krishna.
Thank you so much, Rajdeep. Pleasure talking to Rajdeep always. I get lot of energy by talking to Rajdeep. My dear, old, more than 42, 43 years.
43 years.
43 years of our classmate, whatever it may be, except classmate, everything.
Great.
My benchmate, my floor mate in the hostel. This blue lungi fellow.
Nothing more here.
Rajdeep in white, kurti paisama and all everything. Delhi boy, Delhi chubby, handsome boy. I have grown old, you have become young, Rajdeep.
Thank you for all those words, but I don't deserve that.
I don't say that. You deserve all the honor, Rajdeep.
Good. It was a very enlightening.
Yes, so simple. Is it useful, Rajdeep, for a practicing either diabetologist or endocrinologist or the primary care physician or the physician? So whoever is treating diabetes.
Whatever you have shown here in the slides, it is not. That's what I'm saying. Send us the literature. It's very skills and very practical and clinically oriented.
Yeah,
And
that's
it's
right.
very difficult
See,
to find even the ADA guidelines.
you keenly follow me. You must have observed all the time I go out of the box.
Yes.
All the time I go out of the box and say some of my practical tips, I add it to that. Okay. They're all evidence based. Not only that's not my kahani, not only my story, not only my OPD and my patients, but what I practice is what I preach, and what I preach is what I practice, Rajdeep. Ultimately, patient is my God, so I have to take care of them in a much better way. See,
whatever you told about the EMPA right now, this molecule, it is not available this much of info.
Never, you never get this information outside, Rajdeep. If Rajdeep can contribute one steno, so that he sits with me, so I can dictate. We can make some short practical guide like thing.
Sure. I'll just tell you. Stop private practice. Start institution.
Yeah, that's what. Thank you so much, Rajdeep, for your kind words. Actually, I don't deserve that honor, but you still always say that. But
thank you. I will not take the time of other participants now.
yeah. Any other questions, Ramesh?
You don't know any other queries, sir?
No, check in the chat box, please.
I have seen no queries, sir.
No questions. So no questions means very good. My friend always has some questions. Not that he doesn't know. My classmate is very good at all these things, but to enlighten the audience, the participants, he'll be asking. That's all. Rajdeep is my 43-year-old good friend, my classmate. I can proudly say that I am friend of Rajdeep. He holds a high position actually.
Rajdeep sir, thank you sir. Thank you for asking questions, asking the doubts. Okay.
Presence of Rajdeep itself increases the decency decorum of this webinar. That's it. Okay. Love you, Rajdeep. Love you.
My pleasure.
Yeah.
Thank you very much for your words.
See you much exhausted. I think I'll just stop. Ramesh, can we wind up the session if there are no questions? It's already 90 minutes. I started the session. Shall we?
Yes sir.
Yeah, please.